Okay, next. I'm very excited to introduce the keynote speaker. Dr. Melanie Knoll is an associate professor of clinical psychology at the University of Calgary and a full member of the Alberta Children's Hospital Research Institute and the Hotchkiss Brain Institute. Her expertise is on children's memories for pain and co-occurring mental health issues and pediatric chronic pain. As director of the Alberta Children's Pain Research Lab, she developed a conceptual model of child pain that guide pain research globally, and she has 91, that's more than the first one, 91 peer-reviewed articles. She received early career awards from the International Association for the Study of Pain, the Canadian and American Pain Societies, Canadian Psychological Association, and Society of Pediatric Psychology, and was named Avenue Magazine's in Calgary Top 40 Under 40 Class of 2017. Dr. Knoll chairs the Pain and Child Health Training Institute, a transdisciplinary training initiative that connects scientists and trainees in pediatric pain from around the world and fosters excellence in pediatric pain science and advocacy. She is an incoming executive board member of the Canadian Pain Society and is on the scientific program committees of the Canadian Pain Society and International Association for the Study of Pain. She's very busy. Dr. Knoll is an advocate for pediatric pain management. She co-authored clinical practice guidelines for pain management of vaccine injections, which has been adopted by the World Health Organization. So it's my pleasure to introduce Dr. Knoll.
Hi, everyone. I guess you can turn me up. Everyone hear me? It's usually not a problem for people to hear me. I have French-Canadian background, and I'm very loud, so I know my friend over there will adjust. So thank you so much for inviting me, Rajam, to be part of this summit. There's been a lot of hype about the San Diego Pain Summit, and I've heard wonderful things over the years, so I'm thrilled to be here. Now, I'm going to go out on a limb and assume, and maybe show me your hands, if you work with adults with chronic pain. Yeah. Any people who work with kids with chronic pain? Yeah. This is not surprising for a pain conference, right? Most of us focus on the adult world. But I'm going to take you on a journey over the next 45 minutes or so. And I'll start myself now. Thank you. And I'm going to make the case and show you, hopefully, and it'll be compelling to show you how early painful experiences from the time of birth set the stage for the adult that lies in front of you if you're a massage therapist, or the adult that you work with. I'll start now. I am a Canadian. Any Canadians in the room? Hello. Any Newfies in the room? No Newfies. I'm the only Newfie. Newfoundland. You might not have heard of it, but it's all the way. Thank you. I know a lot of people think East Coast is Toronto. But I live here in beautiful Calgary, Alberta. It's just above Montana and right next to British Columbia. And we are in the foothills of the majestic Rocky Mountains. I love the theme of the conference, which is about, bridging clinical and research, because I'm really passionate about that. And all of my research is done in the Alberta Children's Hospital. So my research lab is across the hall from where kids with chronic pain see their psychologist, from where they do rehab with their physical therapists. And I really pride myself on doing research that actually has direct clinical care. I'm a clinical psychologist, not a PT like I bet most of you are, but I love physical therapists. I think you do a lot of the hard work and actually the work that evokes a lot of emotion in our patients. So we need you. So given that about 5 people in the room work with kids with chronic pain, I just want to set the stage. 1 in 4 Canadians live with chronic pain, kids. So these are things like stomach aches, headaches, limb pain. It can be pain anywhere. It's pain lasting 3 months. So that's 1 in 4 Canadians. And these rates are pretty strikingly similar across the world. Now, not 1 in 4 kids is disabled by their pain, but we find 3 to 5% of these kids are robbed of a normal childhood. There's a lot of disability, a lot of impact. And this has been coined because the rates are rising and the burden on the healthcare system is enormous, 11.8 billion US dollars a year. And it's been coined a modern public health disaster. And what we know now is that this doesn't end in childhood, and this is the link to all of you. We know that 2/3 of kids with chronic pain will grow up to be adults with chronic pain. We also know 50% of the kids that I see in a tertiary level children's hospital, 50% of them have parents with chronic pain. So this is an intergenerational problem. And unfortunately, our treatments work for some, but not many. And pain is not just about pain. We're finding out that even if we do a good job of managing pain in childhood, these kids are at far greater risk of developing psychopathology, so PTSD, depression, anxiety into adulthood. So this is a huge public health problem. Now, what does this have to do with this baby? I'm going to take you on a journey and show that what happens and how we manage acute pain right from the moments of birth can have a lasting impact in terms of whether a child will develop chronic pain to become an adult that you work with that has chronic pain. And it's going to shock you that just 40 years ago, it was widely believed that babies couldn't feel pain. So I am 38 years old. I'm okay with it, so I'm outing myself. I was born in 1981. If I was born with a congenital heart defect, I would have had open heart surgery. They would have given me paralytics, but I would have had nothing to manage my pain. And it really took brave scientists and a mother, unfortunately, Jill Lawson, who lost her baby to one of these surgeries, to show that babies were dying because of this practice. But it was clinically well believed that their nervous systems were too immature for them to feel pain. And it was also widely believed that babies couldn't remember pain anyway. And we know that that's not the case. And I'm going to show you some really seminal studies that showed this. So this was a study by Anna Taddeo and colleagues from the Hospital for Sick Children. And she was examining babies born of diabetic mothers, okay? So if you're born of a diabetic mother, you have to have a lot of heel sticks. They take blood from your heel, okay? So needle procedures. And she compared the babies who were born of diabetic mothers who were getting these repeated heel sticks to babies not born of diabetic mothers, so who didn't have needle procedures. And she found that when she followed them a couple of months later at a vaccine injection, just when the nurses were cleansing the skin, so that's not painful, right? Just when the nurses were cleansing the skin, the babies who had had those early needle procedures started showing fear, distress, and pain expressions even before the needle went in, raising the possibility that those early painful experiences that were unmanaged in the first few days of life actually led to an implicit memory that influenced how those babies experienced pain later on. Another seminal study by Steve Wiseman and colleagues followed kids, young children who had cancer. And these kids had to get repeated lumbar punctures and bone marrow aspirations. So these are pretty intense needle procedures. And half of the kids received proper pain management for their needle procedures. They received fentanyl. And half of the kids received nothing. Now you might be like, why would you not manage pain of a child? You'd be surprised that it's still not well done, even in some of the best children's hospitals in the US and Canada. And you can see here, this is the pointer, yep. You can see here that the kids who did have the fentanyl initially had lower pain versus those who didn't have fentanyl. And then at the time they said, this is unethical. All children need to have fentanyl. So all of the kids after that first procedure had fentanyl. And you can see the kids who didn't get it the first time never derived the same benefit from analgesia as the kids who had their pain properly managed from the get-go. raising the suggestion that not only is pain remembered from those first days of life, but if it's not well managed, those memories can actually influence whether or not a child can benefit from pain management. So I'm going to show you a little video that I think really beautifully in 2 minutes captures the importance of this area. And this is a clip from that video.
The question we get every single day, 6, 7 times a day, is, am I getting a needle today?
There's been an accumulation of evidence over the last couple of decades that if we don't manage pain during procedures, that it can have long-lasting effects. So in the long term, my concern is the possibility of developing needle fears and phobias in children which persist for life.
Our current system for immunizing has holes in it. And one of the big holes, I think, is the fact that people stay away from needles because of pain. My oldest son, who's a big strapping, youth services worker with the province, is nervous about needles. So I don't think he gets as many as he should because he's nervous about them. It's not, and it's common. You see it all the time.
I'm married to someone, this 6'2" man, and honestly, he's fainted.
Imprinting is a bigger deal than we think. You see these big football players who go run into each other on a regular basis for a living, and yet they're scared of a little needle. These formative memories live with us. So when you're a child, there's plasticity. Your nervous system, your immune system are figuring things out. But once they lay the wiring down, that wiring is laid down. So if your wiring is laid down wrong, you're stuck with it because adults can't rewire very well.
And so little life events that would seem pretty benign to a lot of people, because the nervous system is so highly charged, send these kind of people who have had a lot of activation through the roof.
I thought, I can do this. And I wanted the baby more than I didn't want the blood test. And I was good until I saw the needle. I fell on the ground and I started screaming, like I must have been like a wild animal. They had the crisis response team coming in. Nobody knew what was happening because you don't hear these noises from the blood test room. And I wish to God I could just faint, but I'm not a fainter.
I think she remembers last time that she was here. Is that possible? So she's crying because she remembers last time when she came in here, she had a needle.
So we know that whatever we've been doing with these infants and children, the painful experience of a needle is way up there in terms of what they're most apprehensive about.
She was already worked up before it even started because she remembered.
So no one likes to show videos of babies getting unmanaged, painful procedures. This happens all the time. And some kids, I have 3 kids, some of them handle it well and some don't. But this is a baby who hasn't developed language yet. She can't tell you what she's thinking. But as soon as she goes into a pediatrician's office where she had a poor experience, last year or a couple months ago, she starts, showing fear. She starts showing that she can remember what happened. Why is this important? Because about 1 in 10 adults has serious fears and avoidance of medical care, okay? The only difference is, as adults, our parents don't drag us to these procedures, so we can kind of keep our fears and avoidance sort of hidden. But we know that every adult, let's use needle phobias, for example, 1 in 10. So I know a couple of you guys in here have a needle phobia. 1 in 10 have a needle phobia. Almost every adult who has a phobia of, painful procedures had one poorly managed experience from childhood. They remember being held down, or they remember screaming. They remember it not going well. They remember being disempowered. And so how we remember early painful experiences really sets the stage for how we're going to cope with pain, how we're going to cope with healthcare, what we're going to think about doctors well into adulthood. And if I had to summarize about 10 years of research, about 15 years of research actually, including my own, whether we're talking about children with cancer getting medical procedures like lumbar punctures, needles in the spine, bone marrow aspirations, whether we're talking about healthy kids who come into the lab and dunk their hand in cold water That's how some of us experimentalists study pain in the lab. Or whether we're talking about adolescents who are undergoing major painful surgeries like spine fusion or pectus repair, how children remember painful experiences is often a better predictor of how they'll cope with pain in the future than the actual experience of pain itself. So these memories, and it's one of the most robust scientific findings. No matter what context, these memories are powerful drivers of future pain experience. How many psychologists in the room? 1, 2, 3. Okay, 2, 3. But I think it's fascinating, whether you're a psychologist or not, how memory works. I mean, we all remember things from our childhood, right? But memory is not like a tape recorder. You can't play back an experience and have it play back exactly as it happened. So all of our memories are incredibly fragile and susceptible to distortion. And as that physician in that video said, he talked about how children's memories are very plastic. Experience is very plastic. That's very true. Especially in childhood, these memories can really become distorted for the good or the bad. But we find that kids who develop what I call negatively biased or negatively distorted memories of pain, that is the kid who at the time of the painful experience says it was about a 3 out of 10. And then you call them, 2 weeks, a month later, you say, oh, remember when you had your needle? Remember when you had how painful was that? Do you remember being there? And the kid says, it was horrible. It was an 8 out of 10. I cried for 10 minutes. I never want to go back. Some kids, about 1 in 4, develop these negatively biased memories. Some of you, probably 1 in 4. And those are the kids, not surprisingly, who are like that baby. When that baby grows up and can talk, that's the baby. That's the kind of experience, right? The kids who develop these memories are more likely to have fear, avoidance, distress, anxiety in the future. So we're trying to figure out who are those kids and how can we prevent those kids from developing those memories in the first place. And we're finding out some clues. So it's really fascinating that how painful experiences end influences the memory. And this is a classic psychological phenomenon called peak end effects, that you're more likely to remember the worst part of an experience or the ending. So there was a cool study by Joel Katz and colleagues. He's also a Canadian from Toronto. And he followed men who were getting colonoscopies. And half of the men were randomized to have a less unpleasant ending. I know, I can't talk about this without there being some puns. They removed the device. I'm not a physician, okay? But whatever the tube, they removed it slowly, okay? Versus the other half of the men who just had a normal colonoscopy, so they removed it quickly. Now, that's not painful, but apparently changing the ending that way is less unpleasant. So they had the men getting their colonoscopies, and they had them rating their pain. The men in both groups had the same pain experience. But the men who had the less unpleasant ending developed more positive, accurate memories of that procedure. They remembered it as being not so bad. If they said it was an 8 out of 10 at the time, they were saying, it was about, 5 out of 10. And what's more, the men who had those more positive memories were more likely to come back next year for a repeat colonoscopy. It actually influenced their medical adherence. So in the kid world, I call this the lollipop effect, right? No matter what happens, if you make the ending of something better, that's why I need to really go out on a bang at the ending of my talk, so then you'll remember this no matter what, as a good talk. We also find that girls are more likely to develop these negatively biased memories than boys. And we all know, 70% of our chronic pain patients are females. And women are more likely to develop anxiety disorders too. So there are sex differences here that are really interesting. And anxiety is the biggest culprit in everything. An anxious individual is more likely to remember what they expected would happen than what actually happened. And if you're anxious, you expect things to be really bad. So anxiety is really critical. And if I had to summarize where the field of pain is going, it's more and more in this direction. Fear and anxiety are one of the biggest drivers of problems in pain. So I got really interested in this notion. So I've been talking about needles now, and I've been talking about acute procedures. What relevance does that have for chronic pain? But it has long been proposed that one of the reasons that pain transitions from an acute to a chronic state is around memory. And so I was really interested in looking at how memory underlied, there's a dog here, wow. That was very surprising. First time for everything. So here's the problem with chronic pain, and I'm talking about primary pain or idiopathic chronic pain, call it what you will. I'm talking about the pain that I see and treat, and that is pain that kind of comes out of nowhere. Ring a bell? Where people don't know where it started. Sometimes we see people who have chronic pain who had a surgery. Sometimes we see people with chronic pain after a whiplash or like an injury. But a lot of the kids that we see, honestly, it kind of comes out of nowhere at around puberty, right? I'm looking at my pediatric colleague. And this is a real conundrum for clinicians. And it's still, as Rajam said earlier, we need to be humble. There's a lot we don't know about why chronic pain develops. But there's one context that as a scientist we can study pain before it becomes a problem and catch it. And that's these kinds of surgeries for idiopathic scoliosis or pectus repair. We find, and this is only in the last 7-8 years that this literature has come out, that 20% or more of kids who get these major surgeries, so if you have a curvature of the spine, the surgery really involves like opening you up and manipulating muscles. It's very painful, but it's an elective surgery. These kids don't have chronic pain before they have it, and up to 20% will develop chronic pain. This is a problem, but it provided an opportunity for us to answer the question of who's developing chronic pain and why, and what's the role of memory in that transition from acute to chronic pain. Because even the kids that come in that are like, I have migraines, I don't know where it came, it didn't just start as chronic, right? Like it always starts as acute pain. So we followed a cohort of kids from Seattle who were getting these surgeries. They didn't have pain at baseline. And we asked them about their catastrophic thinking. Does everyone know what that is? That's the tendency that when you think about pain, it's just a thinking style. When you think about pain, you magnify how bad it's going to be. You think it's going to be really, really bad. You ruminate about it, so you keep thinking about it over and over again in a negative way, and you feel helpless. You feel helpless about pain. And it's a thinking style. And we asked parents and we asked kids before the surgery what their catastrophic thinking about pain was. They underwent the surgery, they rated their pain, and then 2 months later, we called them on the phone and we asked them about their memories of that experience. So we could see which kids were developing these negatively biased memories, remembering it as worse than it was, versus the kids who kind of developed more positive or accurate memories. And they've been rating their pain, for years. And we found that just the way that parents and kids were thinking about pain prior to surgery was the single best predictor of whether or not they developed these negatively biased memories. I mean, this is controlling for their actual pain experience, the anesthesia, the surgical factors, all the stuff you'd think or physicians would think matter. And it was the psychological stuff, it was the thinking, it was just, and actually how parents were thinking about their kids' pain. Parents who tended to magnify how bad the kid's pain is and ruminate about it over and over again, their kids developed these negatively biased memories of pain. We followed a bigger cohort of kids, and we found same story. Kids who are anxious before surgery, kids who catastrophize about their pain in the first 2 days after surgery, Those are the kids that are going to develop negatively biased memories a year later. And guess what? Once those memories develop, that does underlie whether or not pain becomes chronic. And that's the million-dollar question, right? Like, you know, okay, anxiety influences negatively biased memories, memories are bad, but is this really a culprit in this big modern public health disaster? And I'm not implying that, you know, this is the only factor for pain chronicity, but it's powerful that something so fragile that we can change may be one reason or one culprit for the development of chronic pain. And we showed this, that once those anxious children and children of anxious parents develop these memories, they're remembering it as worse than it was, that is predicting higher pain precisely at the time that it can transition from an acute to a chronic state. And we've shown this in 2 studies. Now, this is really, you know, I don't actually agree with the physician in the video who was like, once those memories are laid down, you're stuck with it. That's a really bleak message, right? And it's not true. It's not true. And this has got me spinning and so excited. And I'm going to end on a really positive note for personal reasons, but also that's where the data's taking us. But, you know, I'm really interested in what kids can tell us, right? Like, what do you remember? But there are lots of memories, and I'm not trying to get Freudian here, but there's a lot of things that drive our behavior that we're not conscious of. We can talk about that on the coffee break. But what's also really, really kind of interesting is that when they've taken, you know, looked at rodents, okay, they've studied pain in rodents and scanned their brains. When pain is initially acute, the sensory regions of the brain are activated. But as pain transitions to a chronic state, the regions of the brain that are activated are the emotional and the memory regions of the brain. So there's a shift. So there's something happening in our neurobiology around memory and fear that are underlying the chronic state. And so I just got a big grant. I'm really happy about it. It's been a few years. To study this in kids. So we have scanned the brains of kids undergoing these surgeries, and we do find that if you compare the brain of a kid with chronic pain versus the brain of a kid without chronic pain, there are differences in how big their hippocampuses are. So that's the area of this is how much I know about the brain. I have a lot to learn. The hippocampus is the memory region. That's different. And the connectivity between the hippocampus and the frontal regions of the brain, the prefrontal cortex, and the hippocampus to the amygdala, the fear and anxiety center, are different in the chronic pain versus acute pain state. And so we now are embarking on a journey to actually look at what are the brain changes that happen specifically in the hippocampus in the transition from acute to chronic pain in kids, and how does that map onto how they're actually remembering explicitly these experiences. Now, I'm also really interested in even the littler kids. So we know that chronic pain develops around puberty. There's something about puberty. At 12 years of age, approximately, we see a huge spike in chronic pain. And I'd say many of your patients probably report having pain as a teenager, right? But I got really interested in memory for pain in the earlier developmental periods, what I like to call the golden period of childhood. That's age 4 to 6. Why is that? Because when you look at how memories develop, that's a period of development where these memories are incredibly fragile. Children are incredibly suggestible. Just the way you talk to a kid can change how they experience the world, can change how they remember things. It's magical. And a lot of things are happening around that time developmentally. They're developing language. They talk nonstop. Anyone have 6-year-old, 4 and 6-year-olds? They talk nonstop. I'm enjoying being alone at the conference. I'm not going to lie. I love my kids, but there's also things called source errors, okay? So you can tell a child that something happened, and they can almost adopt that as an actual memory. Now, there are a lot of ethical considerations around this, and I'm not into lying to children. It's absolutely unethical. But it just goes to show that this whole notion of like false memories and stuff, there is something to that. They're very, very suggestible, okay? And so I got really interested in this idea because I was finding a lot of the anxious parents had kids who were developing these negative memories. Why is that? Why might that be? If you're an anxious parent and your child had a painful experience and that is making you really scared, I wonder how you're talking about it on the car ride home. Or what about when you're filling your husband in on the phone and the child is overhearing you and you're focusing on the negative stuff? Like, how are these interactions that we have every day influencing how children are remembering these experiences? That's me and 2 out of 3 of my kids. We just did a study that was really simple. We followed little kids who were getting their tonsils out. Has anyone ever gotten their tonsils out? It hurts, right? I had mine at 26 and had to get my mom to move in with me. It was so painful. But I'm not a good pain coper, I guess. It's a really painful surgery. A lot of kids get them. We get about 60 kids in our children's hospital a month getting these surgeries. So it's really painful in the first week or 2 to swallow, and then it kind of resolves. And we followed kids before surgery. We scrubbed up, and we actually watched them on the surgical floor to see how anxious they were and how anxious their moms were. Mostly moms. We also had dads. And then they had the surgery. They rated their pain. Same kind of model that I showed you before. But 2 weeks after the surgery, we got them to come back to our research center, and we got them to talk to their moms and dads as they normally would about that experience. We turned on the tape recorders, we left the room. Because we wanted to see, how are these interactions, how's language is so powerful, how is that shaping how children are remembering these actual painful experiences? Then we did a memory interview. And it may not shock you to know that when we looked at anxiety, it didn't even really matter how anxious the kid was. But if mom or dad were anxious before the surgery, those kids developed much more negatively biased memories, which is powerful and also shows how, if you work with a kid, you really need to work with a parent. We were also interested in whether the ways we talk to kids about painful events differ from how we talk to them about other kinds of events. Like, as a society, we're very avoidant of pain. We stigmatize pain. We repress it. A lot of people, even scientists, have said to me after talks, well, it's pain, mostly basic scientists who study cells. They say, well, what's there to talk about? When it's done, it's done. And so I was really interested in an almost anthropological, sociological way around, like, what is it about our society? Why aren't we talking about pain? Are we good at it? And we found that we're not. If you compare how kids talk to their parents about sad things, like someone dying, something bad happening, sometimes traumatic things, they're talking really in good ways about these kind of traumatic, sad events. But how they're talking about pain is not adaptive. They're not elaborative. They're not processing the emotions. This is how children learn to understand experience, through our language, through our conversations with them. So we have a whole line of research that I'll be excited to share with you another time, where we're actually looking at how pain is portrayed in the popular media. Netflix, what are millions of, where are children and parents learning about pain, and why do we repress that? But the big question was, is the way that children are talking to their parents about pain shaping their memories for pain? And we found, yes. Parents who talked and reminisced about these experiences in more elaborative ways, so they asked lots of questions, they pulled for detail. Parents who talked about emotions. I mean, for someone to say, what's there to talk about when you talk about it, lots to talk about. The nurses, the doctors, the thing you watched on TV, there's lots to talk about. But parents and kids who, when they reminisced, they talked all about the pain. So It's about the painful experience, not the ouch, hurt, sting, bad, right? We can talk about the experience without laser beaming in on the painful sensations. And that is a robust finding across the pediatric pain world, that the more we attend to pain, and I'm sure you see this in your patients too, the more focused we are on it, it's not good for outcomes. So I've really argued that, like, why aren't we doing something about this? I think the field has been so focused on how we can improve a child's pain experience. Of course, we want to relieve children's pain. We want to stop their suffering. We don't want a child to have a 10 out of 10 when we can put on some EMLA or topical anesthetic, a bit of numbing cream, or we can throw on the TV and distract them. Super, super powerful, just distraction for kids. So the field has been focused a lot on what do we do in the moment. But there's this totally unharnessed opportunity here to simply talk to children in a different way, to put pain in the public conversation, to really fundamentally alter how they're remembering these experiences. And you know, I'm giving a talk in Toronto, and this woman on Twitter talked about, she's about 30 years old, and she talked about a surgery she had when she was a kid. She's like, I remember my Spice Girls pencil case. My mom remembers it being horribly traumatic. So it's really interesting how the same experience can be recalled differently. And I think, for me, if we've shown that the memory for pain actually underlies why it becomes a problem, let's start talking about this. Let's teach parents, let's teach adults, let's ourselves start framing this. So this is pretty powerful stuff. In 3 studies, only 3 studies in the last 20 years have done anything on memory, trying to reframe children's memories, right? One was in the context of lumbar punctures, so kids with cancer undergoing these needles basically in their spine. Another one was for vaccine injections of 5-year-olds in the pediatrician's office, and the other one was like dental anesthetic injections. And basically all of the interventions just simply did this. They followed kids at those needle procedures, and then after the procedure, like that day or a week later, a researcher just talked to kids about that experience. They focused on anything good that happened. They caught children when they were exaggerating and kind of helped them see, no, you didn't cry for 20 minutes, it was 2 minutes, and then looped them back to the positive. And they helped children feel brave, okay? Simple, 15 minutes. It ranged from a simple statement to 15 minutes. I'm going to show you this study because it's powerful. In this study, they followed kids who were getting vaccine injections at the pediatrician, and half of them were randomized to receive this feedback, pain-denying feedback, and half were randomized to just get neutral feedback, okay? So if you were in the intervention group, you're 5 years old, you had your shot, a researcher comes to your home 3 times over the next year, and they simply say this: when you got your shot, you were a really brave kid. They said you didn't cry at all when you got your shot. It was like it didn't even hurt you at all. That's it. Or if you were in the other group, they said, the day you went and got your shot, they said you first came into the office and the secretary talked to your mom. And just by giving this feedback, those children developed more positive, accurate memories of that experience. So the power of language, the power of just brief conversation and reframing, really powerful. But my big shtick is that, as health professionals, it's not all on us, right? We can do so much, but if parents can be working on this stuff at home, it's going to help us all, right? So we developed an intervention. We call it Reframe the Pain, and then I heard there was a podcast that's called Pain Reframed, so we should get together. Technically, it's not the same. But we basically did the same thing. So we were watching these kids get these tonsillectomies, and we developed a simple, I'm telling you, it takes 15 to 20 minutes. And it's not rocket science. It's It's like actually really simple. We just tell parents, you know what, how your kid remembers these experiences matter, just like I did for you, but I do it in a minute, not 40 minutes. It really matters, and what you say can matter, and kids who develop more positive memories, they'll be on a better track for the rest of their lives. So you can do something about it, okay? We say, when you talk about the painful experience, emphasize anything positive that happened, okay? And they might say, well, what's positive about a surgery? What's there to talk about? Well, maybe there was a friendly nurse. Maybe, sister brought, a stuffy to their hospital room. Maybe you guys got to watch really great movies in the hospital. What movie was that? And just get them talking about the experience, but anything positive, okay? The second principle, help them be realistic. If you catch your child exaggerating how bad it was, and I have a daughter, I mean, she's just a bit more anxious than the other kids. And she's like, she catastrophizes. It's really interesting as a pain researcher. I don't want to remember, it's going to be really, really bad. So Leia is a kid that I would have to do a bit of that with. Not invalidate her, but if I catch her saying, oh my gosh, Mom, it was so bad. I was hurt all day, I couldn't do anything, I'd say, well, actually, no, it did hurt a bit, but remember we watched the movies that day? And remember there were times that you forgot about it? Remember those wicked lollipops, or not lollipops, that's taboo now, popsicles that we had and that really made you feel better? See what I'm saying? So help them be realistic. If you catch them exaggerating, help bring it back. And the final thing, a big culprit in this is children feeling helpless. And sometimes as adults, we don't do a good job of helping children feel empowered and in control. So the third principle is just showing them that they were brave, showing them that they did something that helped, right? So maybe that was like, do you remember you were watching the show? Did you know that's called distraction? You were actually doing something to help yourself. Like, you can do that again. See what I'm saying? That's it. So we taught parents, okay? This is a clinical trial we just wrapped. We had kids come in for the tonsillectomy, and when they came back 2 weeks later, they were randomized to either get taught this intervention that I just taught you, it's that simple, or we taught them how to play with their kid, control group, child-directed play. And then a week later, we called the kids on the phone and we said, what do you remember when you got your surgery? How painful was it? How scary was it, that memory interview? And it worked, guys, and I'm really excited that just that 15 to 20 minutes of instruction to parents, teaching them how to reframe the kids' memory, led the children to develop more positive, accurate memories. These kids were remembering the surgery as being not so scary, not so painful, not so bad. They also remembered it as being less scary than it actually was. So they're actually remembering it as being better than it actually was. And so for me, this is really, really powerful. It's simple. I didn't know if it would work, to be honest. But I think, even if you work with adults, our language and how we talk about past experiences can really play a powerful role. I do agree with the physician in saying that we have a better shot of it in childhood. It's easier to intervene, and I commend many of you who work with pain that's been ongoing for decades. It's not easy. But I hope that this talk has helped you see that, even if we're talking about a 50 or 60-year-old, what happened early in life influenced why they became the adult they are today. And some of the factors are out of their control. There are genetic factors. There are many, factors. But there's something that we can do about it, especially early in life, to maybe offset this progression, maybe for many more kids. But I don't want this talk to imply that we shouldn't manage pain in the here and now. And there's been studies to show that kids who undergo painful procedures, if you manage their pain properly, so you distract them, you put on numbing cream, you do, again, these aren't rocket science things, but it's hard to get people to do them for some reason. If you manage pain well in the moment, even if you don't see big differences, that can lead those kids to remember that experience in more positive or accurate ways. So pain management can have lasting effects that we don't see in the here and now. So with that, I just want to thank, again, Rajam for inviting me to give this talk. I'm really excited we have an interactive app-based discussion, so please ask me anything. I'm going to be here till the end of the conference tomorrow, so happy to engage and talk with any of you about any of this work. But really, all of this work is done by an incredible team of graduate students, brilliant graduate students and trainees, and so I just want to give them a shout out. So thank you very much.
Okay, thank you so much. That was wonderful. And I know that, again, most of us work with adults, and it is kind of one of those things where you're like, this has been going on a long time. How do we go back and fix that or help them with that? So we do have some questions. I don't know how many of them are coming from the room, so please ask your questions, because I'm serious. I'm not going to call on you, okay? Okay, so we'll just start at the top for now, because so far there's only just 4 questions in the queue. So the first one is from Jesse Atkinson. Is this more about parents framing before and after pain experience, or the kid's narrative, or kids' narrative arrive first and working with that?
Yeah, that's an interesting question. I like, Jesse, that you're talking about what I call the bookends of time. So there's what happens when the kid is actually about to have this painful event. But there's the before and the after. I've been focusing a lot on the after. How do you reframe an experience once it's over? But the big culprit in all of this is, well, shouldn't we be trying to prevent this before it starts? So what he's asking there about the kid's narrative first, that makes me think of anxiety, right? There's a narrative if you're anxious about pain that it's going to be really bad. Sorry, no. I can't help but walk around. Right? So there is a narrative about pain. I mean, children have pain. You know, think about the vaccine injection schedule in Canada. Kids are having 20 needles before the time they're 5. So no matter what we're talking about, we all have a pain narrative before another pain experience. And yes, absolutely, Jesse, we should work on that. And I don't know if we really do a good job clinically of this. Maybe some people do. But we're finding also in chronic pain that narrative, that origin story, how kids are relating to their pain, where they believe it all started, that is critical in terms of whether or not they're going to buy in to what you're selling and what you're going to do. So I think the narrative before works, but I think that if we really want to get on top of this and have the biggest bang for our buck, we need to address the anxiety of the parent and the kid before, and there are effective ways to treat anxiety, right? It's a good thing. It's not a good thing to have, but if you're going to have something, probably it's good that it's that and not something else. But the memory after as well. And here's the other thing. You know, a lot of people ask me at talks like, well, they kind of think about the phobic kid. So I have friends who have children, you know, they've just had some bad experiences. It's not the parents' fault. Sometimes things don't go well. Sometimes these kids, like my daughter Soleil, come into the world with these kind of anxious temperaments. It's harder, it's not as simple to fix when a phobia or a fear is really elevated, right? That's when we really need our psychologist colleagues and stuff. But what I love about this research is that, you know, if we're doing this in kids before they develop these fears, we might be able to prevent that kind of snowball that can happen, right? So just talk. I do this on my kids all the time. You know, reframing their experience. Even if it's not a problem for them, it could still have benefit from them. And by reframing experience, you're changing the pain narrative, right? So that's my answer.
Awesome. And that's actually, so we're going to go to a question from Joe Kennedy, which says, what of children with one parent who is anxious and one who maybe isn't?
Yeah. Okay, I don't have an empirical answer for that. So in our studies, like it's hard to recruit two parents. So our research is really around if you have a parent. I mean, if you have a parent that's anxious, it's probably worse if the other partner is anxious too. But you know, it's really around anyone who's interacting with the kid who has a powerful influence. And there's no one more powerful to a child than a parent, right? So even if one of them is anxious, you're at risk, right? The problem with our current system, and it's even harder in the US with billing, and I trained in the US, you know, is that we talk about family-centered care, but we don't really address parental mental health issues. And whether we're talking about acute or chronic pain, like in the chronic pain world, so I didn't get into all my work on trauma and stuff, parent mental health is one of the biggest predictors of whether or not a kid's pain is going to get worse, whether the function gets worse. And so even if you have one, you're at risk. But we know from the child development literature that one positive, you know, adaptive, you know, attachment figure can have huge beneficial effects. So it's called the grandmother effect, right? Like, you know, your kids go to the grandma's house and they're getting treated in ways that you're like uncomfortable with. That's okay, because if I parent in an appropriate way, I can buffer the grandma effect, similar. So one good adaptive model can really counteract some of this stuff. But, you know, in this research, the surgeons were seeing this for years, right? As soon as they met a family, they could feel how this was going to go. So we just published on it, but they've known this for years.
Awesome. Okay, so now we're going to go to a question from Robert Haddow. If the key factors regarding pediatric pain revolve around how we talk about pain with our children, what can we do? Is there a commonly reassuring way we can communicate?
Yeah, you know, I mean, number one, my big shtick is that we should talk about it. I have a whole sociological line of research, a sociocultural line of research, really trying to understand why as a society are we so bad at this? You know, we're all drinking we're all, you know, we believe, we understand pain, but the broader conversation, the broader belief is that when it's out of sight, out of mind, don't talk about it. You could make it worse. You know, and we actually ask parents this, you know, they believe that if they talk about it, they could traumatize their kid. And so I think, you know, I really believe that as pain researchers and clinicians, we need to get pain, you know, and we need to destigmatize it. We need to educate. We need to spread the word, and we need to talk to parents. We need to empower them. A lot of them will do, any parent will do something that they know is going to be good for their kid. Up to now, we didn't even know what to tell them to say. So I think as this research comes out, you know, we have something that we can tangibly say, look, talk about these experiences, they're happening, and here's a way that you can actually talk about it in a way that's going to make the kid feel better. So the principles that I shared are one way, but we also have a huge literature on what you should say and do during a painful experience. Actually, distraction and coping, you know, you're doing a great job, you can do this, take deep breaths, that's all good. But actually reassurance, it's okay, I know it hurts, don't worry, that is actually not helpful. I know. It's surprising. And so we actually have a lot of research to use to share with parents what they can say that can actually be helpful. And I fully believe parents will take this and ride into the sunset with it. And so a big part of my research is working with knowledge translation experts to start getting in media, you know, working with Parents Canada, writing op-eds. Like, we as a community need to get pain into the conversation.
Well, that's a beautiful segue into Carolyn Van Dyken's question of what training do pediatric nurses get in Canadian hospitals, and how is your research being translated into clinical practice?
Yeah, so I love nurses. That's another, like, I love talking to physical therapists. and nurses too, I think. Well, I will say this, and I'm looking at Keith and some of the Canadians. We know in Canada that veterinarians get 5 times more pain education than physicians. So pain education, yes, I know. I just got chills, and I'm like with you. It's shocking. So pain education is actually very poor. I know that I have a child, one of them was born with a chronic lung disease, and Jasper needed to be in and out of the hospital. And I can tell you, the nurses made or broke the situation. I mean, the nurses are the front line. I think nurses and teachers, I think, they're the front line. They can make a huge difference. And I find they're very passionate. A lot of this is intuitive. We also in Canada, I'm sure you do too, child life specialists. These are professionals that are in the hospital simply to make children's hospital experience, like to bring play and to give them like a normal child development. And they do wonderful work with pain management. So nurses are huge, right? Nurses are the ones often giving the painful procedures. And so I think this is something that we really need to spread. I mean, I'm focused on parents, but this stuff applies to health professionals too, whoever's with that child, right? And we have tried to teach nurses to do this in a study with a colleague in Australia. And in that one study, it was hard to change practice. I'm just gonna be honest, right? I mean, I have brought my kids in to get needle procedures. I'm on the World Health Organization guidelines. I come in with my, numbing cream and the iPhone, and they're going to watch Paw Patrol, and I'm ready to go. And even then, there can be barriers where someone will turn to me and say, that doesn't work, that's going to make it work. Like, clinical beliefs are really, really rigid. And so what are we doing? We're spreading the word, we're getting into the public conversation, we're taking our research and trying to make guidelines, practice. There's a lot more we have to do, but nurses, I think, are a real target for this stuff. And they can really, like I give talks to public health nurses that give vaccine injections to kids in schools. One nurse could influence 500 kids that year. So I'm really, really passionate about training the trainer, I guess.
Okay, wonderful. So we do have a question from Keith Waldron about specifically about the studies about anxious parents, thinking about conscious versus unconscious communication. Did the studies measure parents' anxiety via questionnaire, or were the studies looking more at the expression of a parent's anxious behaviors, or both?
We did both. So we got their self-report, and this was really around how anxious they normally are. So trait anxiety. So this is like, you as a person, how much do you tend to feel threat in the world? Okay? We all know our general levels of anxiety, right? Like, probably we're all a little bit anxious because we pursued education and stuff. Definitely psychologists are anxious. So we measured that, so it's self-report, and that's what was really predictive. But we also did code how anxious they were through their behavior, right? So we're on the floor and we're looking at how they're interacting, how close they are to the kid, what they're saying, their body language, when the mask goes on. Like some parents, I mean, the variability is incredible. Some parents are like, see ya, the kid gets wheeled away and the kid's fine. Other parents, they are weeping. I mean it, and I'm not blaming parents, okay? There could be past medical trauma, there could be all kinds of reasons for this, right? I am not blaming parents. I'm just shining a spotlight on something else. I think we need to think really carefully and seriously around social context and true family-centered care. So it wasn't the coding of the behavior that captured it, it was actually how anxious they told us they were. Which from a clinical perspective is good, because they can fill out this questionnaire in like a minute or two, and it's actually predictive of outcome.
Okay, and then we have a question from Curie Schultz, She struggles with the concept of let's be brave, as it has a potential to invalidate a pediatric patient's perception and experience of what they are feeling in the moment. The positive, the realistic makes sense as a clinician and as a parent, but can you expand on the let's
Yeah.
be brave?
I totally hear you. And Carrie, sometimes I struggle with presenting this stuff. Like, I want to be a clear communicator, but I also want to appreciate that there are nuances to this. Like saying the right thing, right? Saying, you were so brave. Oh my gosh, like you handled that so well. You didn't cry at all. If the kid had a bad experience, they're going to be like, what are you talking about? I didn't. So validation is huge, right? Don't lie to kids. I mean, people do. I mean, Santa Claus, you know? Oops, I hope I didn't ruin
what?
Christmas for anyone here. No, but we do. I've written papers on deception. I mean, we do deceive children. I mean, let's face it. We do this in everyday life. But the thing is, and it's hard to measure authenticity, right? But authenticity, as clinicians, you know, is important. But as parents to kids, we can't train parents to go into the room and be a different parent. The kid's going to be freaked out and it's not going to work. So it's about, you know, them implementing this in an authentic way. So the brave piece, I would say, use an example. You know, it's not just, and this is in child development, blanket praise is not helpful. Good girl, you were a good girl, you were brave, that's unhelpful. But what is helpful is specific praise. You know what, Carrie, I thought you were really brave. You know why? Because, you know, you didn't really want to go in, but you went in and you took those deep, do you remember taking those deep breaths when the nurse asked you to? I don't remember. Yes, you did. I remember you took that deep breath. Do you know there's a whole science behind deep breathing? There is. That actually helped you. That was brave that you did that. You actually did. See what I'm saying? Right? Or like, do you remember after, you know, you got a bit upset? Yeah, you did. Validate. But you know, then we watched movies. And you know what? That distracted you. That got your mind off it. That actually helped you. Like, you did that. So I know, Carrie, it's like, it can't just be like, hey, you were brave with no basis for it. And we need to be authentic. And actually, we're flying to Sweden, I know, poor me, to actually learn how to code validation in interactions, because we think validation is critically important. And so no one's really done that in pediatric pain, but we're going to do it.
Awesome. I can't wait to see that paper. Okay, we're going to go to a question from Mark Milligan, who is here somewhere. And is pain control in children different between socioeconomic status?
Yes. It's really sad, actually. There are a lot of social inequities. I saw a study, basically, like if you see African American, this was a US study, African American children received far less pain management at an emergency department visit than non-African American kids. And so, you know, there's not a lot of people doing, I know of 3 people who are starting to really get at this. One is Adam Hirsch, who's in, I think, Texas. But he's doing some really cool work on social inequities where he's using avatars and manipulating aspects of like race, ethnicity, to look at how medical residents are treating patients. And so he's working on how to address this. But there are definitely inequities. I mean, even if you look at who is winding up in a tertiary level chronic pain program. In our samples, they're high SES, they're typically white. We know that our Indigenous youth in Canada, you know, the rates of health issues, including chronic pain, are higher, and they're not winding up in our clinics. So there are systemic barriers to even accessing care. And then when the children finally do access care, oftentimes their pain management is is inadequate. So this is a hugely important issue, and I wish I had a better, I'm just telling it like it is. But I have some colleagues in Belgium who are also doing some really cool work on this, and I think the field is starting to really pay attention. If anyone's going to Amsterdam for the World Congress, there's a workshop just on this topic of inequities in pediatric pain. So.
Awesome. Okay, and then we'll do at least one more. So this is from Laura Xing Su. I'm so sorry if I pronounced that wrong. In one of those studies, did you measure any of the changes in the parent's own perception of the pain experience after communicating with the child? If so, are there any meaningful findings?
Yeah, so this was our first trial, but I've been called ambitious. We went full on for the full clinical trial without showing it was acceptable or feasible or anything like that. So I was so relieved when it worked. But we actually did, we think that one of the reasons why this works is because you're actually improving parents' own self-confidence and their ability to help their kid. Their self-efficacy, as we call the fancy word in psychology. And so we did measure that. We measured whether or not after the intervention, the parents felt like more in control, like they had more confidence in their ability to help their kid. It was it didn't pan out significant in terms of statistical significance, but we think that that's important. And we also asked them about the feasibility and acceptability and would they do this again and was it helpful and all of that. And they overwhelmingly said that it was. We also designed the intervention with parents. This was co-designed. So parents of kids who had gone through those surgeries, we did in-depth interviews with them to see what would be helpful and what they wanted. And they want to know how to help their kid. Because a lot of the kids don't want to take the medicine. I don't know why, but they don't want to take the medicine. And the parents, and I felt this too, because one of my children had to, like I said, had to be on the NICU. When you leave the bosom of good tertiary level care, it's scary as a parent. You got to bring your kid home. It's scary. And so a lot of these parents wanted something to do. And then you're giving them something to do. And you're helping with their expectancy that it's going to help. That's important too. I mean, that's a whole talk on placebo, but that's important. And so, yes, parents are feeling positive. They're reporting that it's positive, and I think it's building their self-efficacy in their ability to help their kid.
Wonderful. So then that's going to take us to a question from Jason Erickson about what resources are available to help educate parents about how to help their kids reframe the pain experiences.
Well, I'll share my resources with anyone. Our children's hospital has already put this in their parent pamphlets for, we call it positive language or positive reframing and stuff. So there are some. Honestly, I just wrapped this clinical trial, and we're submitting the paper. And then I'm working with I know the Canadians probably know about this, the Solution for Kids in Pain. It's a network center of excellence all around how do we move research into actual changes in practice. And so that's what we hope to do, make pamphlets, We hope to give this as a resource to parents before they leave the hospital, right? So I'm kind of annoyed with my own research because we're waiting 2 weeks. Well, maybe we should be getting in there before. Maybe we should be teaching this to them before and teaching it to them right when the kid comes up. Maybe while the kid is waking up from anesthesia, you're talking to the parent about what they can help as soon as that child wakes up. So we're on it, but it's still fresh. But I am not someone who believes that we need the full trial and the 5-year grant and this. We can start doing this. There's no harm in this, right? And so I am fully sharing it right now.
Awesome. Okay, so I know there were still a couple more questions that we didn't get to. So like Dr. Knoll said, she's here. Come on up and ask during the break. So we're going to go to break now, and then we're going to meet back. There's a little typo in the schedule, but we will be back at 10:15. So enjoy your coffee.